hang with me just a minute or two. We've been kind of talking about things that are going to improve outcome, and this is kind of a new concept. Hadn't been around that long. I'll give you some data. I actually got interested in it very early and have done several studies on it. I mentioned my disclosures this morning. I do research for Sequenon and REVO, and I've spoke for Hologic. This has no conflict with this particular talk. I don't know about in your practices or in your hospital, but more and more patients are showing up to our offices with a laundry list of things that are demands. And the good thing about it is I usually say, I'm a perinatalogist and I don't do routine OB. And so therefore, monitoring is pretty much standard of care in anything I take care of. I actually pity many of the generalists that work in my department because, quite honestly, some of the requests and demands are quite extensive. I am a scuba diver, but I am not putting on my swim fins and getting into a tub and delivering a baby. I'm sorry, I'm just not going to do that. Having said that, there is a lot of information out there in the lay press about this particular topic, and in fact, if you Google it, you will find that particularly in term infants, there's a big group of people that say that if you'll delay cord clamping, your baby will be smarter and all sorts of other things. And I'm going to kind of talk about that. So we're really going to look at this from two different points of view. We'll look at the background a little bit, and then I'm going to talk specifically about the term patient because that's going to be pretty easy. But that's the one that if you're out at a level 1 hospital you deal with on a day in, day out basis. Is it unreasonable to do delayed cord clamping? And of course the college has made some statements about that, and we'll talk about that also. And then I'm specifically going to talk about the intervention for a preterm neonate. That's kind of what this is focused toward, and so that'll be toward the end, and then we'll wrap up just a little bit. So the background, placental transfusion, blood volume is, the placenta has a lot of blood obviously in that. We had the cord blood banking group outside discussing their services, and so we all know there's a lot of blood in that placenta and that umbilical cord. We have blood flow. We have different techniques that have been utilized in the literature, and I put some of this up here because I'm going to use some abbreviations in just a few minutes. We're going to talk about delayed cord clamping. We'll also talk about milking, and we'll talk about a few other techniques, okay? My interest in this actually started back in the mid-90s. There were two articles that came out about the same time. One of them was in Pediatrics in 2000. And our article was published right after that, and we took 32 babies and preterm babies. These were very preterm babies, less than 30 weeks of gestational age, and just randomized them to delayed cord clamping for about 20 seconds at the time of cesarean section, and those babies had an increased crit. And this kind of laid there for a long time. Now, I said that was the first study, or these were the first studies that have been done. There had actually been a number of publications back even into the 50s looking at delayed cord clamping in term children, but not in preterm children. And we also noted a statistically lower transfusion rate. Nothing else was statistically significant. Remember, this is only 30 neonates, so it's kind of hard to draw any conclusions about that. Well, there's a number of advantages theoretically. I mean, we know that we have blood carries oxygen. The more blood you have, the more the baby is perfusing. Theoretically, less RDS and less need for oxygenation because there's more oxygenating carrying capacity, if you will. Also, a decreased need for transfusion has been proposed, less IVH in preterm infants, and less iron deficiency anemia. So ultimately the goal as we go from, right to left, left to right, the placentas with all the extra blood in them get paler and paler, and as we delay the time, that neonate's getting the auto transfusion. So once again, the mechanism behind this whole process is improving outcome. It's going to improve perfusion and decrease organ damage. Remember, anytime that we have a perfusion problem or an oxygenation problem, whether it's a preterm neonate or somebody in our ICUs, a mother, they're going to divert blood away from certain organs, non-vital organs, and divert it toward the vital organs, the brain and the heart specifically. And obviously things like necrotizing enterocolitis become a problem because blood will be diverted away from the gut in those particular cases. It also allows for theoretically for a better transition. I mean, if a neonate is delivered and is stable, that neonate can breathe. The foraminal valley will start to close. We'll have several things going on, but it's still getting oxygenated blood, not only from its breath, but also obviously from the mother also. And there have been reports of decreased need for resuscitation. Anemia doesn't seem to be as big a problem, and specifically iron stores are improved. Remember that these are very special cells, okay? You can't almost go through a day without looking at the newspapers, and they're talking about stem cells and about the advantages. I believe now then there is a prospective trial going on with treating unborn children with sickle cell with stem cells, okay? So we're actually getting to a point to where these stem cells may be able to be used to prevent diseases, which is exactly what we thought was going to take place at some point. What are the drawbacks to it? Well, you can have delayed resuscitation, and so I think this requires some clinical decision making on your part. I'll never forget the second delivery that I did at my current institution about 5 years ago was a set of twins that had a total abruption at about 29 weeks gestational age, and we rushed her back, we crashed her, and then this neonatologist started hollering at me because I didn't do delayed cord clamping. Well, the pH was 6.9 on both of those babies, and the placenta was totally abrupted, so I don't know what they thought that was going to happen here. I mean, so you got to use some intelligence. Obviously, if you have a depressed neonate, the last thing you want to do is probably delay giving it to the pediatricians. We also have to worry about hypothermia, and I'll talk more about this a little bit later on. What about is it possible to get too much blood into these neonates? And if so, obviously that in and of itself has complications. I mean, sometimes transfusions, partial exchange transfusions are required for that type of thing when it rarely happens. We always worried about maternal hemorrhage. That's been one of the primary outcomes that has been tried to be diagnosed to see if it is increased. One of the issues with that is the high incidence of what we call maternal hemorrhage. I mean, we know that a significant portion of them, of vaginal deliveries, have more than 500 cc's. It also interferes with blood cord collection. So there are some drawbacks to it. One of the concerning things that I actually have about it is that we don't understand the physiology. I don't like doing something that I don't really know exactly what's taking place. And I'm not going to get way off into this article. It's a very fascinating article, and we've actually started a research project at our institution. It was done by a midwifery service, and basically in the Netherlands. They took 30 term neonates with no complication. All these neonates had category 1 tracings, and the midwife delivered the baby, immediately set the baby on the mother's abdomen, and they started doing continuous Doppler at that particular point to see exactly what was going on. For the most part, her endpoint was, when she clamped the cord, was when the cord stopped pulsating, though that varied, and I'll kind of get a little bit into that here. Initially, about 20% of them, this is arterial flow. So remember, arterial flow is going back to the placenta. 20% of them, even at the initial evaluation, they couldn't see any arterial flow. About 40% of them had very good flow, but you can see a wide range there, up to 9 to 10 minutes. You'd continue to have pulsation. And some of them were spontaneously stopped for a variety of different reasons. Once again, for, up to 10 minutes. Remember that this is flow away from the placenta. Away from the baby toward the placenta. So this is net negative flow. Now you would think that there's venous flow coming the other way, and so there's net positive. However, is that really what's happening? And the answer is, we don't totally know, we don't totally understand. We do know that in general these crits are higher in these neonates. There was a big time difference between when the arteries and the veins stopped pulsating in all of these neonates. Once again, there was positive flow. The artery stopped first in 7 of the babies. In 8 of the babies, the venous stopped first, so flow was to the baby. So their conclusion was, actually umbilical cord blood flow was longer than previously been described. They actually had a case that went on for 16 minutes where blood flow was continued to be recorded by Doppler, which seems excessively long to me. It was affected by a number of different things, and I didn't get way off into this, crying, breathing, etc. Remember, arterial blood flow is toward the placenta, and that could theoretically have a negative effect on some of these neonates. And the blood flow is unrelated to pulsation, and so that's probably not really related, or that's not probably a very good endpoint. I don't think very few people here in the United States are suggesting that as a good endpoint. Even many of these mothers that are wanting this done, they want to delay it 5 minutes, and there's a pretty good bit of data regarding that. And so anytime I want to find out what's going on, I always go to the literature, and a Cochrane review is a very good thing, although it is a little bit concerning because the Cochrane review had 15 randomized trials with a total of 3,900 patients. Well, whenever you average or do the math on that, these were not large trials, okay? These were a relatively small trials that they put together. Now, a total of 3,900 infants, I mean, that's about how many you guys delivered Erlanger, isn't it? Yeah? So, I mean, most big centers could do this kind of trial in 1 year and probably get better data because it's more standardized. And so a lot of people kind of felt like the college kind of jumped the gun on this, probably even more so on the preterms, and we'll get to that in just a minute. But they basically, in the Cochrane review, they broke these 3,900 patients into 2 different groups. That group that was less than 60 seconds and that group that was greater than 60 seconds of delay. Their primary outcome was postpartum hemorrhage, which once again is going to be difficult to be able to tell. They also tried to look at some maternal and neonatal morbidity. Their secondary outcomes were maternal blood loss as well as other morbidity, both from a maternal and neonatal point of view. What they basically, the big primary outcomes are listed here. I'll just tell you up front that they are not powered to really give a lot of the answers to this. What they did show was what we know, that there is positive flow in these neonates. Now, it's not to the degree that we see in preterm infants, but there is positive grams per deciliter in the neonates that had delayed cord clamping. It was still present after 48 hours. However, at 3 to 6 months, that had totally gone away. More importantly, they showed a 38% increase, statistical increase, in the need for phototherapy. Even though clinical jaundice was not statistically significant, many more of these children actually had to undergo phototherapy, which is not a free intervention. So there is an intervention that is required to more of these babies, 38% more, 1 in 3 almost, whenever they have this. So their author's conclusion was delayed cord clamping is likely to be beneficial as long as the access to treatment for jaundice requiring phototherapy is available. And so they felt like that it probably was, that phototherapy is a pretty benign thing. The other big benefit, and really what the college came up with, was they don't really see any problem with it. However, is there really a benefit here in the United States? Where it really is a big benefit is probably in a third world country where iron deficiency anemia is such a problem, particularly in children. A couple of other myths that are out there. We've always had the gravity myth. This is the only study like this. This is actually was published in The Lancet 2 years ago. It's out of Argentina, and they basically tried to determine if holding the baby lower than the level of the placenta was actually necessary. So it was just a prospective randomized trial. All of these neonates after vaginal delivery had delayed cord clamping for 2 minutes, and they used weight prior to and weight after as their endpoint, and they showed absolutely no difference. And that kind of makes sense. There probably is a pressure gradient here that's driving this whole process. And this is a fairly significant study. When I say that, there are about 400 patients in this study. This is the only study like this, though, and once again, I'd like to have more information. So it really doesn't matter where you hold the neonate. I know that whenever I do C-sections, we used to hold them way down low, and I was always worrying about contamination coming back in. There was a very small study, and a conclusion got made, and somehow it got into the press, and I honestly didn't bother to include the information other than to tell you that, once again, if you go and Google this topic, you're going to see a lot of people talking about babies being smarter if they had delayed cord clamping, okay? And so this is the only study that's actually evaluated this. It made it into the Journal of American Medical Association. They randomized children to either have delayed cord clamping of 3 minutes versus less than 10 seconds. And they looked at some short-term outcomes, but we're really interested in the long-term outcomes. Now, the long-term outcome is by questionnaire alone. They looked at ferritin levels, so these children were seen back for their 12-week evaluation. And you can see there the delayed cord clamping versus the immediate cord clamping. There's, once again, about 150, 175 patients. When you looked at these babies at 1 year of age, there's no difference in hematocrit or hemoglobin or ferritin levels. Iron deficiency anemia was no different. Also, whenever they did the questionnaire about meeting milestones, there was no difference between the two groups. And so the best information we have right now then is that is not that information that is out on the web is not correct, and so that would not be a reason to do that. My personal conclusion of this data would be that it's probably not going to hurt. I do think that if your patient comes to you and she wants delayed cord clamping, you need to mention phototherapy to them. I think that would be very, very important. As far as trying to overcome some of their biases going in, I personally find that it's not worth arguing about. It's not a thing that I necessarily jump up and down. If they want it, after I talk to them about that, then I go ahead and do that normally. There do not appear to be any long-term effects. It doesn't matter where you keep the baby, and waiting until the cord stops pulsating is probably a waste of time. Now, I really want to talk about the important ones here, and that's the preterm neonates. I mentioned that just a few minutes ago with that study that I did. Once again, the Cochrane database did an analysis in 2012, and there's been a number of studies that have been performed since 2012. They're not included in this that need to be included, but these are small trials. 15 divided by 738, you're going to get a lot of small trials, and anytime you have small trials, then mistakes sometimes get made, particularly in meta-analysis. And I'll tell you that Dr. Adair and myself were involved in a big group that were in the process of starting a very large trial where we were going to do 1,000 babies, and it had already been submitted to a number of IRBs. And then the college came out with their statement, and we didn't feel like that we could continue that trial, and so we stopped the trial before it ever got started unfortunately, and we're left with the information that we have right now then. And until somebody finds something on some of these meta-analysis, I don't really think the college is going to change. And most everything is positive here. Once again, the thing that's concerning to me is that I don't really understand all of the physiology that's going on in these particular cases. So the study groups are immediate versus delayed, and some of these did have milking. We'll get into that in just a minute. They were interested in outcomes like death, severe IVH, periventricular leukomalacia, which I'm not really sure why they would be looking at that in this particular group, or how they think that would be caused by delayed cord clamping, but at any rate, and also some of these had neurodevelopmental outcomes. So here's, we'll cut to the chase here. When you looked at all 750 of these babies, there was a 58% reduction in the need for iatrogenic support. That's very significant. The incidence of necrotizing enterocolitis was decreased by 38%. Also highly statistically significant. Transfusions were decreased by 39%, and phototherapy was no different. Now I want to remind you that most neonates that go to the NICU, the incidence of hyperbilirubinemia is very high in that group anyway, but this particular intervention did not seem to worsen that. So we had 3 that were highly statistically significant, and I would suggest to you that those 3 are very, very, very important outcomes. So the author's conclusion were less need for transfusions, better circulatory. Oh, am I having trouble? I must be touching something. Don't touch this. Isn't that a song? Okay. Sounds like something my wife says. Well, at least I got y'all awake now then. All right. Less need for, I don't know how I can keep going now then. Less need for transfusions, better circulatory stability, less IVH, which obviously is major, and lower necrotizing enterocolitis. Those last 2 are huge when we're talking about outcomes of preterm neonates. Insufficient data. What just went across the screen there that you saw was don't touch this. No. It was there's insufficient data for any of the primary outcomes that they actually were going to study. So yes, we have some information, we have some positive things, but there's not enough data. ACOG sometimes does things that I can't really understand. Sometimes they want way too much data, and then sometimes they're willing to jump on something right away. And I will say that this data is very, very promising, but this actually became standard of care several years ago now then. They basically say that term babies, you can do it, you don't have to do it, it really doesn't matter. Preterm babies, less than 32 weeks. ACOG recommends this, and there is data to support that. I wish we had a large randomized trial. I do not think that will ever happen now then in the United States. Let me present a couple of other trials. Another meta-analysis, this looked at babies less than 28 weeks, and there have been a couple of different studies that really tried to dissect this problem out, and where the benefit seems to be, the earlier the gestational age, the more important this process is. But they took a look at this, looking at similar outcomes, and this was published 2 years ago in the Green Journal. They showed better blood pressures in the babies that had delayed cord clamping earlier. Temperature was no different. Some of the studies have shown difference, and of course we know, I know we try to keep our OR hot. I'm constantly having to go in there and make that adjustment. I don't know, I see a bunch of people nodding their heads over here. It is so frustrating to me. I mean, these babies are very sensitive to changes in temperature, and I know I like to have it cool in an OR, but I'm in the business of getting better babies, and so therefore my discomfort until that baby is over in the incubator and is wrapped up in saran wrap is not my primary concern. It's about that neonate. Some of these studies have shown babies that core body temperature were significantly lower, and we're actually doing a study right now then on that. Marked increase in hematocrit, decreased transfusions. The bilirubin in these babies was statistically significant. There was a lower incidence of transfusion. Once again, this is in the very premature babies. All of the big outcomes were positive. A couple of them were positive. Total IVH, highly statistically significant, just like we'd seen in the other one. Severe IVH, there wasn't that many babies. There is a trend there. I think it was 0.07. NEC, it was 0.08. Once again, very low numbers in these, but mortality was actually better if you had delayed cord clamping. So that's very promising. What about cord milking, and what am I talking about? I'm basically talking about taking the cord and just stripping it toward the fetus. In a term baby, that'd be pretty easy to do. In a preterm baby, I will tell you that from a cardiovascular point of view, we really don't know what the effects of that are. But there have been a number of trials, and they've suggested this for a couple of different reasons. First of all, you don't have that delay, if you will. You don't have to worry about resuscitation. You know, I can do this real quick. I can clamp the cord. I can hand it off to the pediatricians who are right there. That's one benefit. The other benefit is the hypothermia. So this has been suggested. This particular study took a look at it. They showed improvement in hemodynamic stability. And they talk about a technique here, and they didn't show a lot of difference between the two, between historical controls, which are delayed cord clamping and the milking, so they felt like they were very compatible. All right, one of my residents came to me and asked me about a research project a couple of years ago. I guess it's been about 3 years ago, and because I had this interest and I knew the literature, I suggested that our standard of care at our institution is delayed cord clamping for 30 minutes, or excuse me, 30 seconds. That's how long this talk is, 30 minutes. Yeah, don't touch this. That's it. And I got 3 minutes, but I can do this, okay? So, then we had this milking, and so the theory would be, why don't we do delayed cord clamping, and then after the delayed cord clamping, milk half of the patient. So it was a prospective randomized trial. We really didn't show anything in any difference between the two groups, except whenever we started looking at the less than 30-week babies. And when we started looking at them, we started seeing some positive effects. And so one of our studies that's going on right now then is actually trying to power this to look for some of these outcomes. I'll be happy to send anybody this if you'll give me your email address. Last month we actually did a article in the OBGYN survey looking at all of this. And many of the problems that I've kind of mentioned to you that I'm kind of concerned about were discussed in this particular article. The milking the cord and the cardiovascular effects are concerning. The temperature, and we actually have a prospective randomized trial going on right now then. The theory being, why not milk and to see what the difference in the temperature is, because keeping these babies at a particular warm temperature is very important. I still think a large trial needs to be done. It's not going to be done. There's nothing we can do about that. So in conclusion, term infants in the U.S., doubt there's really any benefit. Also, harm, phototherapy, plus minus. I'm not going to argue about it. There is a benefit based on the information that we have in the literature for preterm neonates. The ACOG jumped out there and said it was standard of care. And the last one is milking the cord. There's still some unknowns and it needs to be studied better. And so with that, I think I'm going to stop. I think I stayed